trial that is important to be known. So patients after surgery were randomized into receiving pertuzumab, trastuzumab versus placebo, and they were followed up for 10 years. So the primary endpoint of this study was the invasive disease-free survival, and this was positive and met by the study. But when you look at the subgroup analysis, this benefit was only driven by the node-positive patients, and for the node-negative, it wasn't really that significant. But remember also that this comes then after 2 cycles of paclitaxel, trastuzumab, and pertuzumab, and that was the end of her neoadjuvant treatment. So of course this was an amazing clinical response, but you would expect the pathology to tell you that there was a significant residual disease, which has happened for this patient, and we managed to use the data of Catherine's study. So Catherine's study has looked at that particular group of patients, and they were randomized into receiving adjuvant trastuzumab versus KICC. And not only this study has met the primary endpoint, which is the invasive disease-free survival, as you can see, with a hazard ratio of 0.5. It has also improved the overall survival of those patients with a hazard ratio of 0.7. And this was consistent in all the subgroup analyses. So just to sum up, if you have a newly diagnosed HER2-positive breast cancer, if the tumor is more than 2 centimeters or node-positive, we are on the left side of the diagram, please start your patients with neoadjuvant treatment with dual blockade, that's the standard of care, and then send them back to surgery. After surgery, if the patient has a complete pathologic response, you just complete your adjuvant treatment, pertuzumab, Herceptin. Sometimes you can also consider Herceptin alone in the adjuvant setting if the patient does not really have very high risk factors. And if the patient has residual disease, and then they will benefit from the switch to KICC. Now, coming to the low-risk patients, which we'll talk about in the next few minutes, you can send your patients after discussion in the tumor board for surgery upfront, and then you can review the surgical specimen. If the patient is surprisingly node positive, that's when you can apply the data from the affinity study, and then you give them the dual blockade. And if the patient is node negative, there is actually another brilliant study, the Tolane study, that you can actually use to de-escalate and then spare your patients the toxicity. So another question also I will cover in just one slide is the post-adjuvant treatment and the use of neratinib. And this has been looked at by the Extenet trial, where after the completion of 1 year of anti-HER2 treatment, patients were randomized into receiving neratinib or a placebo. The study was positive in terms of the primary endpoint, and the disease-free survival was better for those who do receive neratinib, but I'm not sure how many of you are used to this drug because you use it in the metastatic setting. And it's really a drug that comes with a lot of side effects and does affect the quality of life of the patients. So as much as it appears as one of the standards of care on the most of the scientific society guidelines, but it didn't really translate into our change in practice because of the toxicity profile of that drug. And for the low risk, remember those ones who are less than 3 centimeters, node negative breast cancers, Dr. Tolane had looked at de-escalation of chemotherapy and then gave them 12 weekly dose of paclitaxel with just Herceptin, 18 cycles, and this has proven that there was no compromise of the disease-free survival of those patients, and this is actually a good option that you can offer to the patients so that they can benefit from good outcomes by receiving the anti-HER2, but then also you won't compromise their quality of life. Now, I think this is my last slide. Oncology cannot survive without clinical trials, and clinical trials cannot survive without oncology. So I really want to thank everyone in this room who referred their patients to one of our clinical trials. I also want to thank Roche for sponsoring this trial because it has really given a huge opportunity for our patients to access those cutting-edge medication. And here I'm talking about ProHER trial. You know, we have other trials for breast cancer patients at Aga Khan, but then also at NCI. So those patients were randomized into the IV form of Perjeta Herceptin versus the subcut form, which is Phesgo, available in the country. And then they underwent surgery, and then there was a crossover from receiving a subcut Phesgo in the hospital setting, but then also at home. And those patients were followed up. And I wanted to update you. All the patients that we managed to enroll in this study have had a complete pathologic response. And I would like to thank you for your attention, for listening to me. And this is a photo 2 weeks ago for our ProHER trial patient. She completed her full year of Phesgo, and we were celebrating her. Thank you.
We must admit that Dr. Manuel gave a very good speech, and she saved for us a lot of time. And the amount of time that has been saved, 8 minutes, cannot be wasted. Should the insurance or the patient can afford. As you are still working on the other modalities of payment, and after high risk, or put it the other way, in the neoadjuvant setting, they could not afford pertuzumab, but they were high risk. But you are giving them trastuzumab with chemo. After the 4 cycles, now they can afford to be treated with the pertuzumab plus trastuzumab. Now you are aiming at the 18 cycles. Once you have hit the 18 cycles of trastuzumab, are you going to do pertuzumab alone, knowing that heterodimerization, H to HR through heterodimerization, needs to take place for you to benefit, and that you need that trastuzumab backbone for it to benefit from pertuzumab?
I hope I got your questions. Herceptin in the adjuvant setting rather than the dual blockade, provided that the patient, of course, is achieving a complete response, knowing that the data for the adjuvant setting was really for the invasive disease-free survival rather than any benefit in the overall survival. Of course, for those who can afford the medication, you would want to offer them the best. Let's assume they are high-risk patients, bulky nodal involvement, tumor more than 5 centimeters. Those ones, if they can afford the dual blockade neoadjuvant, adjuvant, provided that they have a complete pathologic response, you can just continue the treatment as much as tolerated. We unfortunately find ourselves in this
directed therapy. Those of you who see HER2 positive breast cancers would wish to use HER2 directed therapy, but do not have access to HER2 directed therapy. Can you also raise your hands up? Because I know there must be some. Yes, so both ways, there are those who cannot afford, and there are those who can afford, and we just have to do with what we can, isn't it? So, any questions? Now, for those of you who have HER2 positive breast cancer and cannot have access to HER2 directed therapy, can you tell us what you do with them? Can we have anybody answer? Any hands up? Or you do nothing with them? So, just a question of you just look at them, or do you offer anything? Dr. Abeid Athman, can you tell us? Any mic? I think we can.
List for the single agent trastuzumab. So I think now there's no reason for any patient who has been diagnosed with HER2 positive breast cancer to miss the anti-HER2 targeted therapy. This is the message I want to the anti-HER2 targeted therapy. This is the message I want to convey. Thank you.
Thank you. Dr. Athman. Anybody else with a question?
Also, maybe from my experience, since now that we have Phesgo available
Who is speaking? Please introduce yourself.
Profits me.
Huh? Oh. I told you I can't even hear the direction from where she's talking. The echoes here is quite something. Okay.
Yeah. So I just wanted to add that now Phesgo has been registered in the country and it's really available, and I really find it a very good option to use for our patients. So sometimes Okay, but don't tell my patients that I'm doing that. But sometimes I look at my patients and I evaluate their BMI. If they are on the high side and they are financially constrained, I just suggest Phesgo because it's a fixed dose. And then if we go to the IV form, the bill will be much higher. So Phesgo is really a good option. It's available, registered in the country. The price has come down. It does not depend on the patient's weight or anything. So if we can push for at least the first 4 to 6 cycles in the neoadjuvant setting, if the patient can afford that one, at least we have done, we have impacted their outcomes by at least considering those medications.
Okay, so the principle of any HER2 is better than no HER2. If you can get some, but then it would be better to push for as much as there is available. Okay. Any other comments?
Here, Prof. My name is Dr. Jacqueline Majuma. I'm an oncologist at Jaramogi. My question is for HER2 residual disease. I thank Roche for the availability of trastuzumab. So a patient that has been treated with the neoadjuvant taxane plus trastuzumab post-surgery, what is the experience? I'd like to hear more from Dr. Manel. Thank you.
Good.
Sure. So, a few years back, not everyone could afford KICC, trastuzumab deruxtecan, and those patients were treated by only a whole year, and usually those who cannot afford Herceptin cannot afford the dual blockade. KICC cannot afford the dual blockade. So those patients were treated. They completed the 18 cycles of Herceptin. Some might have recurrence, some might not have recurrence, but unfortunately, those, for example, they were treated in 2021 or before, are now coming back with the recurrences. So keep in mind that also doing 18 cycles of Herceptin is better than doing nothing, and they will still benefit from Herceptin. If Herceptin is the only option they can access, let them access it, because that's better than not receiving it. Yeah.
Thank you. And of course, the elephant in the room, if you had used them as separate agents before, then tell us the difference that you are now seeing now that you're using it as a combined fixed dose combination.
Good afternoon.
Afternoon.
My name is Omolo. I've had the experience to use Phesgo, and it was under a research. But the response of the 2 participants that we had was really overwhelmingly positive.
Thank you. Omolo, if I may ask,